Today's workshop is around behavioural change and looking at catheter-associated urinary tract infections. My name's Karen Shaw, and I'm the Infection Prevention and Control Lead for Public Health England's AMR program, and I recognise a number of faces around the room. Can I just see, have most of you been here all day? Yeah, so you've seen the talks this morning. So the real meaty part of today's session is really the session that Anna and Eric are going to do, not my bit. So my bit is just setting the scene and really outlining why we're here. For those who tweet, please do. There's a hashtag for the conference, but also hashtag ImproveIPC. Please follow me on Twitter. I have a personal goal. So why are we here? I'm just going to whiz through this because we've seen this morning a lot of the slides that I'm presenting, and also what is quite interesting is a number of the pictures and the infographics come from the Public Health England infection health matters that we did just a few months ago. So they're freely downloadable for all of you to use. So that's that just when you're going out speaking, if you want to use those, please do. You just have to Google Health Matters infection. So why are we here? We know from this morning that E. coli bloodstream infections are on the rise, and if we don't do anything, they will keep going up. Fortunately, we've seen from a number of people that the increase has plateaued a bit. So we're still going up, but it's not going up as steeply. So what's the problem? We know E. coli bloodstream infections are causing about 40,000, it was actually 40,580 cases of E. coli bloodstream infections last year. That's huge. And we know that at the height of MRSA, the MRSA ambitions that we had, at the height there were 1,366 deaths. Well, now we've got 5,738 deaths from E. coli bloodstream infections. So if you weigh it up, we know we've got to do something. We know those patients that are in the elderly, frail category are the ones more at risk. And we saw this morning. The most common source of infection is really the urogenital tract. So that's why we're here today. We can target other sources of infection, but today we're talking about urinary tract and specifically catheter-associated UTIs. We know the patients that have got these infections, 32% have had healthcare interventions in the past 4 weeks, such as antibiotics. 21% have either had a urinary catheter inserted, removed or manipulated in the last 7 days. And there's also categories around other devices, but we're just focusing on urinary catheters. So we've had a number of national interventions. Now, Anna's a psychologist, and she has completely different terminology to me. So she's going to explain a little bit of a difference in the terminology. So we all would normally talk about the high-impact interventions. Is anyone aware of the care bundle high-impact interventions? Yep, so that's what the Infection Prevention Society has just updated. And that's based on EPIC 3 guidelines and NICE, and it's based on the evidence around what are the interventions that we can implement to reduce catheter-associated UTIs. So that's what we call intervention. Anna is going to explain this in a different way because these are actually behaviours. So what are the top 10 behaviours or interventions we would say would reduce a catheter-associated UTI? And they're the ones that we see in the care bundle. So these are the things we know we have to do to reduce or prevent a catheter-associated UTI. But we also know we don't do them. So this workshop is about bridging the gap between what we know we should do and the behaviours that aren't happening. So on that note, I'm going to hand over to Eric, who's done some great work with the London Health Innovation Group looking at bundled approaches to reducing catheter-associated UTIs.
Hi everyone, thanks Karen. I'm Eric Barrett, I'm from the Health Innovation Network. I'm a Senior Project Manager within the Patient Safety team. And just quickly on what our role is in London. So we are the Academic Health Science Network for South London. We're a member organisation and we work across the South London region, so we've got 12 boroughs that we oversee. And part of our role as the NHS is help to speed up the adoption of innovations into healthcare, because on average it takes about 17 years from idea to actual benefit for patients for innovations to happen. So we're here to help speed up that process, but also to help connect some of the dots as well. And so, as I said, we're a membership organisation, so we help to share best practice between sites, bring people together and add value in as many ways as possible. And one of these ways which we've been trying to add value is through our catheter care programme. So for 3 years, we worked as a South London collaborative, working with 9 acute hospitals and 8 community care sites. And as we all know, catheter care is a multifactorial approach to getting improvements. And so what we wanted to do was try to simplify that approach as much as possible and make it as digestible and easy as possible for each of our member organisations to deliver good care within what we felt were the important pillars. And so hence we came up with the 6 core pillars within the middle, which you can see. And so ultimately what we achieved through this programme, we saw a 30% reduction in CAUTIs according to NHS thermometer patient safety data. And so that's something which we're really proud of as a result. And we put that down to a lot of behavioural interventions for how we got there. And so what we did, and you're very welcome to access our website, and you've got the details coming up where you can access a lot of the materials which sit within each of these bundles. So you can see here that we have a catheter care passport. People can download that, and this was co-designed with patients and also with Age UK. We have a dementia-friendly version as well. Also, we had within the campaigning and awareness section, we have a digital pack where people can do campaigning, take part during Catheter Care Week to raise awareness amongst staff around catheter care and good practice. Some of the behavioural elements we built into that was, for example, getting staff to make a social commitment via social media, and so we had catheter care pledge cards where staff were saying what they're going to do to improve catheter care, and making that commitment socially via social networks we think is a really useful mechanism. So that was the work that we've been doing over the past few years, and we want to go a step further and look forward to see how we can actually get a lot of these behaviours to these staff-focused behaviours to stick, and also getting more and more staff to do it. And so we've recently put a bid together which went to the Health Foundation's Behavioural Insights Research Programme. And what we were looking to do, we proposed testing 2 research questions. The first research question we were looking to address was around how we can apply behavioural science to fully understand and adapt the process of implementing those interventions that I was just talking about. And the second part to it is actually looking at some of those individual interventions. And so one example would be, as a behaviour, we want more staff to secure catheters more frequently and make sure that they're stable. And so what the intervention may be that we'll test is encouraging ward staff to take specific steps to improve catheter securement. They may be things like prompts on or near the catheter device, so perhaps a sticker or something like that. But part of the work is about scoping what these interventions will be before going ahead and testing them. Another example of where behavioural science interventions may come into this. Part of the issue is around we want more staff to be looking to trial without catheters. And so what can we do in order to nudge staff to do that? Perhaps one of the interventions could be, for example, using an electronic catheter tag as an indicator for clinicians to make timely reviews of the catheters that are in place. And ultimately, we want to have similar outcomes to what we saw with the 30% reduction of CAUTIs in our hospitals, but also we want to be spreading this more widely as well. We have an ambition as part of this programme to do that across a further 20 hospitals by the end of the research. And as I've kind of touched on, it is all about changing clinicians' behaviour. We hear all the time how different behaviours happen in different trusts. So, for example, around giving nurses the confidence where they don't feel that they're confident in perhaps trialling without catheters and waiting for a doctor's permission to do so. But also some of the other clinicians' behaviours we'd like to see is doctors getting more involved with the overall programme of catheter care as well, and not just leaving it to the nursing staff, because we're finding that there's quite a divide in terms of the communication between staff. So what we're going to do is we're going to test behaviour-focused interventions that NHS staff can take up easily and they're cheap to implement, and we're going to see the impact that these have on an already proven catheter care programme. And we certainly will be looking to produce a series of resources, including a toolkit which is available for frontline clinicians, but also to help with policymakers to make decisions around overviewing their catheter care processes within their regions. And also, obviously, we'll look to release a series of published papers as well. So we presented to the Health Foundation on Monday, and we were looking to hear back today from them, but they said they're going to tell us tomorrow. So I can't tell you if we're successful or not yet, but I'm confident we will be. So this is the sort of schedule we're looking at. And I've mentioned that the first phase, we've got a double diamond research approach here. So the first diamond there is about the discovery phase. We're going to find out what are the behaviours and interventions that staff would like to address and feel could have the most impact. And then the second diamond is actually testing those innovations. And then ultimately we'll get to a position where we'll be able to share the findings from that and try and roll out spread and adoption of these as quickly as possible. We mentioned that this is a behavioural insights talk, and so just reflecting on the review phase of that process that we just had in the previous slide, I believe Anna's going to talk a bit about the behavioural change wheel which UCL developed, which is this. Certainly there's a number of different health behaviours within that which we'd look to go through and see how they relate to catheter care. It is quite an involved and complicated model, so but it's obviously taken a long time to develop and therefore very useful as well. We'll also be using another framework which is known as the EAST framework, which stands for Easy, Attractive, Social and Timely, which has been developed by a Behavioural Insights team. And we'll be combining our findings from these two approaches and applying behavioural insights to influence healthcare professionals. So what we mean by behaviour change already in, or behavioural insights in healthcare, I'm just going to give a quick couple of examples of things which are already in place, which some of them I'm sure you're well aware of. For example, I'm sure we're all well aware of the Hello, My Name Is intervention. And ultimately that campaign is simple and timely prompt that's easily incorporated into a clinician's day-to-day work. And that's our aim for the work that we're doing. Another example is this letter here. It went out to a series of doctors, and what this was mentioning around fewer antibiotics per head of prescribed in neighbouring practices than your own, which has shown a significant impact on reducing prescribing of antibiotics. And the last one, the sign here, these are put up in A&E departments and was co-developed with the Design Council. And what they found was that the factors which influenced aggressive behaviour from patients within A&Es was actually not to do with alcohol or drugs or the like of patients coming in. It was actually not understanding the process of being in A&E and all the stumbling blocks and the frustrations, for example, waiting in different departments and the like. And so what the Design Council found was that having these signs up and then relevant sections from the sign in different places of the pathway actually improved the patient experience and reduced the numbers of incidences of aggression within A&Es. And so these are just some very simple, affordable solutions to implement change behaviour, and we're certainly looking to do that for catheter care in the future as well. So fingers crossed we'll be successful with the bid. Either way, we will certainly be doing work in this space. And just so you can look into what we're doing, certainly contact me if you want to find out more. Within the bundle of interventions, we've got, for example, in procurement, we've got a lot of work where we kind of talked about what we felt were the most cost-effective catheters to use, and about tips for procurement teams in order to streamline the numbers of products they have in their department, amongst a lot of other useful interventions. You can tweet me, and also all of our interventions and that model is on our website, which is there too.
So I'm Anna, I'm Deputy Head of the Behavioural Insights team at Public Health England, and I'm a health psychologist. Are any of you behavioural scientists? No. I hope you're reasonably interested in it, because we are going to talk about some of the frameworks involved in behavioural science today. I'm going to explain to you about some work that I'm doing with UCL, the Centre for Behaviour Change there, where Susan Mickey leads a team of health psychologists and other behavioural scientists. We're doing what's called a strategic behavioural analysis. I'll explain what that is. I'll probably talk for about 10 minutes and then get each of you involved in two tasks. One that's really going to help us with the review, and one that's really to give you some sort of hands-on experience of what a strategic behavioural analysis is. So this just describes, as briefly as I can, it's a method for understanding whether interventions in a particular policy area, so CAUTI here, are addressing the key behaviours and drivers using appropriate behaviour change techniques and interventions for delivery of those techniques. So it's a combination of looking at the literature for drivers of behaviour and suggesting intervention components, and then considering what live or national interventions are happening at the moment and what policies are already being delivered, and then using behavioural science frameworks to try and match those up and look at where the gaps are. So these are the aims of the current strategic behavioural analysis that we're conducting. So we want to identify the people and behaviours that influence the prevention of CAUTI. We want to identify the influences on behaviours, identify and describe the content of UK-wide implemented interventions, investigate the extent to which barriers and facilitators are targeted by implementation interventions, and investigate the extent to which these are being delivered using appropriate behaviour change techniques which are relevant for the theoretical driver of the behaviour which is being targeted. The two things there that are in red are related to tasks that I'm going to be getting you involved in. So, as Eric mentioned, the Behaviour Change Wheel is the scientific framework that underlies a lot of our work at the moment in Public Health England. Again, developed by Susan Mickey and her colleagues who are working on this review. It was formed to help intervention designers use evidence-based behaviour change interventions, and it's a way of making behaviour change and intervention design more accessible to practitioners and policymakers. But as Eric said, it is actually a little bit more complicated than I think Susan Mickey may realise. It's based on a systematic review of frameworks of behaviour change interventions, so they synthesised 19 frameworks and brought these together. At the hub of the wheel is a model of behaviour change, and around that there's 9 intervention functions. So I know Karen mentioned that we think of behaviours and interventions very differently, but if I give some examples here, the intervention functions listed here are broad categories by which we can change behaviour. So education and training, restriction, enablement, incentives, environmental restructuring, modelling, coercion and persuasion. and then they are linked to 7 policy categories which are considered the way in which you can deliver the interventions. These are communications and marketing, service provision, guidelines, legislation, regulation, fiscal measures, and environmental and social planning. So this is the COM-B model, which sits at the centre of the behaviour change wheel. Going through this helps us to understand what factors initiate and maintain behaviour and what needs to change for the desired behaviour to occur. So there's 3 things here. We've got capability, and that's divided into psychological and physical capability or ability to enact a behaviour. We've got motivation, which is divided into reflective and automatic mechanisms that activate or inhibit behaviour. And then we've got opportunity, which is the physical and social environment that enables the behaviour. All 3 of these need to be present for a behaviour to occur, and behaviour occurs as an interaction between capability, opportunity and motivation. It was inspired by US criminal law, so in order to prove somebody is guilty of a crime, they need the means, the motive and the opportunity. So the only difference here is the means being the capability here. So it's an easy way to help you sort of conceptualise the model. So it is linked to a much more complex framework of behaviour called the theoretical domains framework. So that's lying around the outside of the COM-B model. This was brought in, it's reduced to 14 domains from 83 different behaviour change theories and hundreds of theoretical constructs. So although it's very simple, the COM-B model, there's an awful lot of detail behind it. And it was originally designed for investigating influences on healthcare professionals' implementation of guidance behaviour, so highly relevant for this. Although it has been now extended to all sorts of behaviours in healthcare and wider things. So it covers cognitive, affective, social and environmental influences on behaviour. So these are some of the behaviours, although I think some of you may know these as interventions. Here we're calling them behaviours that we're going to focus on today. I've selected just a few of them to give us examples that we can use. So assessment prior to insertion, so assessing the need for catheter with clear indication, including exploring other options. Aseptic practice, comply with aseptic technique for insertion, review and care, including decontaminating hands before and after patient contact. Documentation, I'm actually going to forget the ongoing review bit there because we've got that in the behaviour underneath, and it's easier to do this kind of behavioural analysis when you're really specific about the behaviour you're talking about. So this third one is about documentation of date of insertion, induction for catheterisation, catheter size, type of catheter and planned date for removal. And the final behaviour we're going to look at today is reviewing the ongoing need for the catheter. I'm going to be asking you shortly to get into small groups, and you'll be picking one of those areas. So if you can have a think about it now, you've got handouts there as well which says it, details it again. But if there's any you're particularly interested in, then have a look at that now. Usually we would really specify the target behaviour in a great deal of detail here. We don't have a lot of time for the workshop today, so if I can just direct you to stick to healthcare professionals' behaviours, and you can choose any of the settings that are relevant to our review, which is going to help us, which is primary care, community care, secondary care or nursing home settings. So you need to specify what you want someone to do differently in order to achieve the desired change, when they need to do it, where they need to do it, how often, with whom and in what context. So we're going to go into a little bit of detail. This is the last 3 slides now before we start the task. This is going into more detail on the capability element of the COM-B and introducing the theoretical domains which are associated with the sub-elements of this section of the capability part of the model. So when we look at, you're going to be choosing the behaviour of the ones that I just showed and then focusing either on capability, opportunity or motivation, because you won't have time to do all 3. So start thinking about the behaviour that you had in mind now from this list, and consider it as we just look through some of these. So the way that this is going to be used in the review, what you're doing today won't be used in the review because obviously the review's based on scientific literature. But the review will actually categorise what we find in the literature in terms of drivers and barriers for CAUTI, and it will code those drivers and barriers into the theoretical domains framework and COM-B, so that we have a whole list of drivers and barriers to CAUTI categorised into this framework, which is then linked to intervention functions and policy categories in the behaviour change wheel, which then enables us to sort of see where the gaps are compared to nationally implemented interventions and join them up, and then we can see where we need to go from there. So psychological capability is pretty simple. It's knowledge, awareness. Do they know that they need to do this behaviour, and do they know how to do this behaviour? Memory, attention and decision processes. Are they going to remember to do it? Do they have the attention at that time? Is there anything in the environment perhaps to help them remember to do it? Behavioural regulation is about self-monitoring. So are there any systems in place to help them realise, have I done this? And have I done it to the required standard? Physical capability is about having the physical skills to actually, for example, insert the catheter. Are they able to do that physically? That's often not very populated in these sorts of behaviours. The physical skills are usually not the problem. The next section is on opportunity. So we have social and physical opportunity. These are defined as all the factors outside the individual that can make behaviour possible or prompt it. So the social part is about social norms and interpersonal skills. Do they see others doing the behaviour? So the questions down the side are expanded on in your handouts, because then it helps you to try and think about these behaviours from this perspective. And the physical part is about whether factors in the environment help or hinder. So it's about time, resources, prompts and cues. So the last one in this section is about motivation. There's reflective and automatic motivation, reflecting two parts of the system. So motivation is defined as all the brain processes that energise and direct behaviour. The reflective system is slower and more deliberative and more logical, and the automatic system is fast, instinctive and emotional. So it's not just goals and conscious decision making. It includes habitual processes, emotional responding and analytical decision making. So there's a greater number of TDF domains here, not necessarily because reflective motivation is more important. To the contrary, it's actually less important, we've found now, but it's just a reflection that when they designed the theoretical domains framework, the existing theories that they synthesised were all focused on changing attitudes, which is where the literature used to be, and thankfully is now moving away from that and trying to change the social and environmental context, which has more of an impact on our automatic thinking than it does on changing beliefs, which is actually much harder and less effective. So the automatic processes involve emotional reactions, desires, drives, impulses and reflexes. So moving on to the group task, the most important thing for the review that we'd really like your help with, and that was also done at the Patient First conference, is to brainstorm in groups programmes, interventions or policies that are currently delivered nationally in the UK, where the primary aim is to reduce infections arising from catheterisation for UTI in primary care, community care, secondary care and nursing homes. So we have done this for secondary care and nursing homes at the Patient First conference, but it doesn't hurt to do it again. And for primary care and community care, we haven't done it at all. Obviously, we'll be talking to other stakeholders and doing a search of the grey literature and talking to policymakers to try and help us understand the full picture of what's happening nationally. But it will be really valuable to get your input here as well. So I'm just going to ask you to note down, there'll be post-it notes given out, any national interventions that you can think of, and to stick them on the 4 sheets at the back. There's one on secondary care, one on primary care, one on community care and another on nursing homes. So if you can just take 5 minutes to do that, doesn't matter if you do it on your own or in groups, and then we'll give you a shout when 5 minutes is up. And the next part of the task is using your worksheets to think through one of those behaviours in a bit more detail using the COM-B model and the theoretical domains framework. So if you just choose one part, capability, opportunity or motivation, it will give you a chance to think about that in more detail. I'm sure you've considered some of the reasons why healthcare professionals are not doing the behaviours that they should be. But this is just a way of really helping you to think through in a more comprehensive and systematic way how to do that and how to think in this way. So you'll have about 5 minutes for the first task and 20 for the second task, and then we'll have 5 minutes for feedback at the end. It's a nice sort of checklist. If you are thinking about designing an intervention, this is only one part of it. This is trying to understand what the determinants or factors influencing the behaviour is, or implementing, like what's affecting why a behaviour is not implemented, why something's not happening. So you can sort of do a checklist rather than just going, oh right, I think it must be because people don't believe that it's going to help, or people are too busy, or people don't have enough time, and you can just brainstorm and think all that. But this says, well, actually, what about capability? What about opportunity? What about motivation? All three of those things have got to be present for the behaviour to occur. So often people think a lot about changing beliefs, but actually it's all about changing the environment, particularly in this case, I think, making the processes that people need to follow really sort of embedded in their everyday practice so that they don't have to remember, they don't have to pay attention, they don't have to think about it. It's shaped by the environment so that they don't have to, you know, it's sort of sixth sense to just, right, I need to do that. They're monitored in when they're doing it, they know whether or not they've done it, they get feedback somehow, and all of this needs to be sort of integrated into the system within which people are working for CAUTI to sort of be prevented, I think.